Okay, welcome to this snippet, and we're going to be talking about the essential illness scripts of disc herniation. We'll also be looking at bias correction using differential diagnosis. So I hope this is interesting for you, and let's get on with it. So the essential illness script we have here, severe, very severe back and unilateral leg pain and posterior leg pain. Now, I understand that you can have bilateral leg pain from disc herniation, but don't forget what we're looking at here. We're looking at the average disc herniation, not every single variation. Flexion and extension are both impaired almost equally. The obligate functional loss is the patient can't walk. It's not that he can't sit down. The patient can sit, but not for very long. But they cannot walk. They limp. The straight leg raise is very, very positive. This isn't 10 degrees less than the other side. This is a straight leg raise. It's reaching 30 or 40 degrees or even less. Sometimes they can't even get the knee straight. It's so acute. All range of motions are severely affected, and there is a deformity, a rotoscoliotic kyphotic deformity. The outliers here is a negative straight leg raise, which is probably caused by a contained disc herniation or possibly an atypical biomechanical dysfunction. You can worry about those in differential diagnosis. Bilateral herniations do occur. They're not particularly common. They're also called extraforaminal herniations. They come much more laterally. They hit the nerve itself and not the dural sleeve. So what you get then is paresthesia or neuropathic pain, depending on the level of damage, and a radiculopathy. So no back pain at all. The disc herniation, unusually for us anyway, can go median or paramedian and compress the dural sac rather than the dural sleeves. And obviously, if it goes heavily enough, you get a Caudery-Quiner syndrome. But initially, it may not do that. It just may be dural pain. Disc herniations at L3 or higher are very rare. L3 disc herniations, which is the most common of the high ones, account for maybe 5% of all disc herniations. As you go higher, they become even rarer. You can have old patients. I understand that the range of this is usually somewhere between 35 and 45 or 50. But I've got a friend who is 65 now, and he just blew out his L3 disc, which is rare in the first place, and he did it at 65. And when they did an MRI of his spine, they basically said that he had the spine of a 20-year-old. So when you retain these hydrated discs, which does happen even into 80 and 90-year-olds, these can herniate the way. Now, when they occur in 80 and 90-year-olds, it's a real problem because the patient is already basically buggered by the age, and then you add this in as well, and it's a real problem. And this can occur in very young patients, as young as 9 years old, I think it's been recorded. Okay, so a radiculopathy. We have an EIS for radiculopathy. We should have one for each of the conditions. This is less of an EIS than it is what a radiculopathy contains. Now, it may be one of these, more of them, or all of them. And often it's not a matter of whether they have a hyperreflexia, for example, but whether it can be detected clinically, which is the other issue. So we're looking at a segmental distribution of positive or negative neuropathic pain. If there's damage to the nerve, you may well see neuropathic pain. Hypoesthesia, paresis rather than, and these two are hypoesthesia and paresis rather than anesthesia and paralysis, simply because of the multi-segmental innervation of the skin and the muscles. Hyporeflexia, and almost always paresthesia. Any one of these, with the possible exception of paresthesia in some really complicated cases, but for the average condition, any one of these would denote a radiculopathy. Now, if we look at an EIS for chord recliner and pre-chord recliner, as we said, the disc herniation, if it goes median or paramedian, it can compress the dural sac if it's not too massive. If it goes further than that, it can then start compressing the root cells, and you can have chord recliner syndrome. So pre-chord recliner syndrome, we're looking at this being a disc herniation, but now the signs and symptoms are bilateral, and everything you would expect to see there. Now, when I said positive and negative neuroscience, I mean this is incomplete. You're not seeing the sadoanesthesia or paresthesia. You're not seeing urinary incontinence, all the rest of this stuff. You're seeing evidence of multi-segmental radiculopathy at L4, L5, and possibly S1, but below that, S2. S3 and S4 may not be attached, in which case it's generally not a sign of the chord recliner syndrome, but it should do. Multiple roots are being hit. Now, for chord recliner, you've got all the same stuff you had before, the massive disc herniation, if this is being caused by a disc, of course, but now you're going to see much evidence of more severe effects. So neuropathic pain and so on, but now you're going to see this paresthesia in the saddle area. And remember that it's not paresthesia in the saddle area as an isolated finding. That paresthesia running down the backs of the leg includes the saddle area down to the medial thighs into the knee. The patient's not going to say, I've got pins and needles in my crotch. They're going to say, I've got pins and needles in my legs. And then you ask them if this includes the crotch area. And also urinary retention or incontinence. Now, incontinence is really bad. I mean, basically the nerve's damaged and there's a good chance they're not going to recover control of their bladder. Urinary retention, that may be because the phylum terminale is extending further down than it usually does, and you're hitting that. So you're actually seeing an upper motor neuron lesion in part. So this is a mixed upper and lower motor neuron lesion instead of what should be a purely lower motor neuron thing. But the retention may also be due to hypertonicity caused by segmental facilitation, possibly. I'm certainly not guaranteeing that. So looking at differential diagnosis for bias, these are then really atypical biomechanical dysfunction, lateral stenosis, and again, we're looking at unilateral stuff. If sacroiliitis or severe sacroiliac joint dysfunction, fractures, adherent radiculopathy, sciatic adhesions and piriformis syndrome, if you like, spondylolisthesis, and neurological tumors. Now, you go through this list in your head, and maybe not all of them, but the ones you're thinking of, and you decide which test will disprove this. And this is really what you're trying to do. So you want a very sensitive test that is negative for this. So if it's an atypical biomechanical dysfunction rather than a disc herniation, the straight leg raise in this will be negative, or at least essentially negative. It may get positive as you bring the leg further up because it's rotating the pelvis, which is stressing this. The dysfunction, and this is particularly true of sacroiliac joint problems. But if you bend the knee, and it actually can get more movement, and it gets worse with the knee bent. This could still, though, be a contained herniation. The difference between the contained herniation and a non-disc lesion is that, in this case, the contained herniation progresses. These biomechanical dysfunctions tend to come on very suddenly over the space of minutes, if not immediate, and then it stays there. Generally doesn't get worse, doesn't get better over a period of time. It only gets better or worse depending on what you're doing, but over a period of time, it's not progressing, if you like. Lateral stenosis is an extension problem. This is not flexion and extension. This is an extension problem, and flexion may well relieve the pain as well. The straight leg raise may be positive with this, but you've got a different history entirely. And if you do PAs over the spine in these people, the degeneration will make itself felt into a stiffer end feel rather than the spasm that you get from a disc problem. Sacroiliitis is a severe sacroiliac joint dysfunction. First off, Fodin's test is going to be positive with these almost certainly. You can actually do an objective Fodin, or you can do the other stress test and reproduce this SI joint pain. So you've got those alternatives, plus the fact when you start doing PAs on the spine, this is not nearly severe enough. But with sacroiliac, that straight leg raise can be extremely positive. These tend to be worse in extension rather than flexion as well. Fracture, typically any fracture here is going to be a major issue if it's looking like a disc herniation. It's going to be extremely painful. There will be a trigger event in the form of trauma or minor trauma if it's a pathological fracture. The straight leg raise is going to be positive, but it's going to be positive much higher up. Adherent radiculopathy. This is where the spinal nerve actually gets trapped by adhesion. So you're going to have a history of an injury to the back, usually in the form of a disc herniation, prior disc herniation that's left adhesions. But there will be a fairly significant trauma to the back. Sometimes it's iatrogenic when they're injecting into the area, but there will be that. The pain may be dural if the dural's involved in the adhesion, but if the nerve's involved in it, you'll get no somatic pain. This will be neurological. So, and it'll all be about flexion. In this case, when they bend forwards, you're going to stretch the nerve, you're going to stretch the dura, and this is where you're going to get a positive straight leg raise. Of course, it's going to be positive as well. And when you do your PAs again, you're not going to find this extreme reactivity over that level. Sciatic adhesions, which is misnamed piriformis. These are almost entirely caused by trauma directly to the side of the hip that damages the piriformis muscle. It bleeds, and you get adhesions formed between it and the nerve. This isn't about the muscle tightening up and loosening. This is about adhesions. So the straight leg raise is not going to be positive, but you're going to have to do more rotational and adduction maneuvers to get this to be positive. Instead of doing a straight leg raise, again, the lumbar spine, when you do PAs over it, will be negative. So easy enough to distinguish. And there'll be no back pain. Spondylolisthesis is an extension problem. It's also bilateral, flexion may well ease it. So you're not going to see that flexion impairment. And neurological tumors, whether it's cord recliner or a nerve root, a single nerve root, will lead to the signs you see, the neurological signs you see, far outweigh the symptoms of this. So, and again, PAs are not going to make a big difference. So what you can see is that PAs play a big role in determining whether or not it's a disc herniation. But it's not down as an EIS simply because everything is painful when you do PA, when you have a lumbar problem. So that's the EIS for a disc herniation. Going along with the previous video, I hope that helps you make this diagnosis with more confidence and faster is the main thing. We haven't really talked about neurological testing, and you'll get that on the course, but I would say that, does it really matter whether this is an L4-5 disc, an L5S1 disc? Does it really matter? Does it matter whether you do a straight leg raise when you've got everything else going for you? These are sort of icings on the cake. And really, it's when the straight leg raise is negative that makes you scratch your head and wonder what the hell's going on. So a lot of the stuff we do is really not necessary to make that diagnosis. And honestly, your treatment of an L4 radiculopathy is exactly the same as your treatment for an L5 radiculopathy. In principle, the detail is you're going to be treating a different level, but in principle, it's exactly the same treatment. So it really doesn't matter. Anyway, that's it for this week. I will talk to you again soon. Take care, everybody. Bye-bye.